Good afternoon, everyone, respected judges. Myself, Dr. Ghazal Patnaik, and I shall be presenting our work on revolutionizing ocular tuberculosis treatment through CORDS calculator and how to optimize this calculator for improved patient outcomes. So why the need of this? The purpose was that the prevalence was varied between the southern and the northern part of the India, and that could be due to the lack of standardized diagnostic as well as a management criteria. So the exact incidence cannot be estimated accurately. So the primary objective was to evaluate the application of this collaborated ocular tuberculosis study calculator in real life settings, and the secondary objective was to examine the two crucial components, that is chest X-ray and the tuberculin skin test or the Montus test. We redefined these components and aim to enhance the overall accuracy of the CORDS calculator. So it was a retrospective study from 2007 to 2016. All the ocular tuberculosis patients, those have received anti-tubercular therapy and had a minimum follow-up of 6 months after the stoppage or discontinuation of the ATT were included. And the primary objective was evaluated with the help of concordance rate, and the secondary objective was evaluated with the utility of the other radiological tests as well, and appropriate statistical techniques were involved. So little bit about the CORDS calculator. It is easily available through online tools. You can just Google CORDS calculator or oculartb.net and something like this comes up. Patient details and the clinical findings. If you put calculate, something like this comes up as a result that guides in clear lines that what is the probability amongst the uveitis experts in international platform whether they would consider therapy of ATT or not. So let's have a look about this calculator. Nothing hi-fi or high science is needed, just the basic requirement which a physician has at a primary healthcare level also can get this idea sitting at a remote area. So you can see the name, the age of the patient, and all the different countries are also available here. Once you put all the details, then you come to clinical phenotype, whether it is anterior, intermediate, pan, retinal vasculitis, and similarly amongst them they have different subtypes. So after that you just have to put the details of these three tests, that is tuberculin skin test, IGRA, and the chest X-ray. Not necessarily everything. If you don't have, they have the parameters like positive, negative, or even not done. So after that you have a clear reference that whether ATT needs to be started or not. So from this we calculated the concordance rate, and as you can see we evaluated between chest X-ray and the HRCT amongst the concordance and the discordance group. And we found that if we took both of them, the concordance rate is around 70%. However, if there is a strict adherence, then it decreases to 33%. Also, we noted that the phenotype is very important. And the second important thing is multiple recurrences despite an adequate anti-inflammatory therapy. A suboptimal anti-inflammatory therapy could lead to multiple recurrences, so that has to be taken into consideration. And serpiginous choroiditis has been most commonly associated. Systemic radioimaging apart from HRCT or chest X-ray, that is gastrointestinal tuberculosis or CNS tuberculosis, could also help in providing supportive evidences. Other options could be included in this online tool, that is recurrences, the value of the Montus test, and other ocular investigations like polymerase chain reaction and biopsies. So to conclude, it not only depends upon the clinical features and the lab investigation, we need to have the local epidemiological factors, the availability of the drugs, and the physician perspective so as to evaluate the efficacy and to reduce the emergence of the multi-drug resistance of the ATT. And this online calculator is a very valuable tool, and with this proposed improvements could increase the accuracy as well as the relevance of the tool. In a nutshell, this is very, very economical. You just need to have a mobile with a working network, and in any part of nook and corner of the country, you can get an idea how to proceed with that patient who cannot go to higher centers. These are my references.